Good morning, everyone. It gives me immense pleasure to share the dais with my seniors and my teachers. So we'll be discussing on ocular trauma, expert-guided approach to diagnosis and management. So most of the ophthalmologists will encounter patients with ocular trauma in daily OPD. It may range from small corneal foreign body to ruptured globe. The vision may range from 6 by 6 to NPL. Some conditions may even be sight-threatening. Patient's expectation can be unrealistic considering the high cost, and the outcomes can also be unpredictable. On top of it, there can be a lot of medical legal problems. So we will be giving a comprehensive view on ocular trauma. Okay. So I welcome Dr. Manoranjan Das to start with his cornea part. Thank you.
Thank you, Piyush. So, good morning, all of you. So today it gives me immense pleasure to back to with the ocular trauma presentation, which we have been privileged to conduct again here in Cochin. So now, as you know, my topic assigned to me is very specific. It just gives us a overview of corneal tear repair, the principles and the management. So with this, I have to proceed. I have no financial interest for this presentation. This is a global incidence. You can know that WHO has described about 55 million people usually experience this ocular trauma every year, and it average 2 to 3 lakhs people by number they come into play for this ocular trauma management. So blindness is the major cause of unilateral blindness, and this mostly occurs in younger individuals with the age group of 25 to 30 and of about. And this is how the patient comes to us in the ocular clinic. And when it comes to the eye clinic, so you can see the various layers of eye is involved, and you can also see the various zones of the globe which is involved. So accordingly the management differs, but the basic thing is that the history taking is the main cause, main thing which you have to really make sure that you elicit it in the way of like mode of injury and the activities they or he or she was doing, the velocity of projectile object which hit, or is there any scope of sterile trauma or infective trauma, is there any risk of retained intraocular foreign body, or the trauma with any vegetable matter, or like risk of endophthalmitis or aggressive treatment management in specific cases is needed. So visual workup starts with the visual acuity, and then with the pupillary reaction has to be is seen, and before that we should install a topical and anesthetic drops so that the patient really comfortable to cooperate with us. Slit lamp as far as possible is mandatory. Fundus examination is optional, of course. Slit test has to be done when you think there is a leak in the antechamber, from the antechamber, and then imaging to diagnose and management. So X-ray is the basic test which has to be done in all medical legal case, and this will locate the radiopaque isodens foreign body in the orbit, and also will give an idea about the orbital rim fracture. Simultaneously, we need to go for a CT scan, which is the gold standard for the treatment, because it helps to localize and helps to detect the foreign body, and also characterize whether it is metallic or non-metallic foreign body. However, the sensitivity differs from 50 to 70%. B scan can also aid in the assessment of the localizing foreign body. Also, it will give a assessment of the posterior segment and the degree of damage. Other modalities can be ultrasound biomicroscopy and gonioscopy can be selectively done when we see a foreign body or you suspect a foreign body in the angle. MRI is absolutely contraindicated in metallic foreign body injury, but more effective MRI is in localizing non-metallic foreign bodies or wood, vegetable matter, or plastic. So pre-op management starts with the tetanus injection and systemic antibiotics, so the fluoroquinolones and third generation cephalosporins. Then on basing after having this started, then you can decide whether to go for a conservative management or surgical management. Conservative management mostly is preserved for the lacerations or the wound which is less than 2 millimeter, and there is no intraocular tissue lodged in the wound or in the foreign body is not lodged in the wound, and there is no other structural damage of the eye. And residual states can be negative, but residuals might be showing positivity. But of course, the contraindication would be in the children and uncooperative or mentally challenged patients. So surgical management, the goals as to restore the structural integrity and the restoration of the visual optimal function. So it also helps to manage the posterior segment pathology afterwards. So next, coming to the principles of corneal suturing. First principle is the selection of the suture material. That should be monofilament 10 nylon sutures with a reverse cutting spatulated needle, which has to be hold at the junction of 2/3 and 1/3 of the needle. And next will be the selection of the suture material. So selection of the material will be 10 or 11 nylon for corneal injuries. Scleral injuries is 8 to 9 nylon, and conjunctiva is always with acryl. Simple interrupted sutures is always advised to go for this type of suture. 311 or 211 sutures are done with knots to be being buried in the superficial area, not at the wound site. So principle 2 is the depth of suturing and the angle of suturing. Depth of suturing is to be 90% depth, as well as it has to be perpendicular to the corneal wound. And if it is a clean cut tear or a linear tear, the equal depth of suture should be assessed in both sides of the wound. So coming to this routine schematic diagram, you can see this is a normal A picture shows the normal suturing with a good depth and symmetric suturing in both the sides. Picture B shows the asymmetric suturing, the symmetric suturing looking like, but it is a not full thickness suture. So it is a not full thickness, not also adequate suture. So it's a shallow suturing. Shallow suturing will lead you into a posteriorly gapping. And then third suture, C diagram shows you the full thickness suturing. And in a trauma case, if you have a through and through endothelial through and through suture, then it will leak after the AC is formed, and also that is a chance of infection through that port. And D and E shows the asymmetric suturing, irregular suturing, which will lead to either posterior surface or anterior surface overriding. So this is a diagram showing part A is the best suturing of the good apposition, and the B picture shows the overriding of the edges. So coming to the principle of third principle, this is for only for lamellar or self incision. The principle here is that when we do a suturing for this, so we have to oppose the posterior lip equidistantly or symmetrically. Whether the anteriorly or from the surface, epithelial surface, it looks abnormal, that one small side, one is a small end, one other larger end. So ideal is that we should aim at the posterior segment symmetry, not the anterior side or epithelial side symmetry. And here when you bury the knot, it has to be the thicker side, not at the thinner lamellar side. Next, once you put one suture, then you should always remember about the principle of zone compression. So this is both the sutures. When we suture, one suture is over, when the second suture, you go for the second suture, and there the distance between the two sutures only maintains the zone of compression. Ideally, if the zone of compression overlaps each other, then only you will have a tight, watertight compartment. If the zone of compression doesn't overlap, you can see the picture B, which shows the wound leak. This is the picture of a good zone of compression and watertight suturing, and this is how if you suture the second, it will be cramped suturing. Then principle 5 is the suture placement strategy, and ideally that goal is to compress or flatten the periphery with the longer sutures, so that the center sutures which are in the visual axis has to be smaller and just well opposed. We need not tighten it, minimally opposed. So linear tears involved in the visual axis, and this is the linear tear. You can see the video, and So principle of no touch technique has to be followed in all these suturing cases. So ideally we should make this is not an ideal this thing I'm showing knowingly what is has to be done probably this case to start with. We should have done a side port and put either pylomine if it is lens status is seen clear, or you have to put side put and do the visco elastics and then start suturing. Ideally speaking, suturing should start at and the suturing should start at the limbus and then at the angles. Thus, I'll show you the principle of suturing next. This is the principle of suturing. So these are the anatomical landmarks actually. So here anatomical landmark is the limbus is one of the landmarks. Neck and the vessels or the pigment line epithelium and the cut angles or the laceration angles. So we have to suture always at the in this case we don't have any anatomical landmark is the laceration angle. So we are suturing the laceration angle. Here also we could have started at the limbus first. So limbus has to be done first and then go inside the cornea to manage. So coming to the corneoscleral injuries, this is you can say this and that once you have got this case, you have to see whether iris is prolapsing or not. If there is iris no prolapse, you can suture either way, either from this limbus towards the sclera first, or if there is iris prolapse or there is vitreous in the AC, once you cut it, then you finish the add the first suture at the limbus and then second suture subsequently into the cornea if there is iris prolapse or vitreous prolapse. If there is this case there is no iris prolapse, so we have decided to close either way. Wherever we suture is okay for us. But this is the stellate laceration and this is always a nightmare for all the surgeons. We have to assess the apex of the wound always because that is mostly lacerated. Usually we see this type of injuries when we have a bottle injury, glass injury, the soda bottle like in this thing, or that stone injury, blast injuries. They will always have a irregular stellate injuries. So this can be addressed with intermediate bridging sutures with central purstring sutures. So corneal lacerations with iris prolapse is the one more entity which you have to always think about before the suturing, because before suturing either the prolapse iris has to be reposed back or it has to be excised. If it is less than 24 hours, it is always almost always healthy, so it can be reposed back. If it is unhealthy, even if it is less than 24 hours, it shows the signs of necrosis and maceration will be there, and then infected rim or infected edges will be there, then we should excise it. And of course, if it is crosses beyond 24 hours, it has to be excised. So post-operative management, topical antibiotic, antifungals, judicious use of topical steroids, cycloplegics, and posterior segment evaluation has to be done. Suture removal, however, is ideal to do at 3 months, but anyhow, any loose sutures or broken sutures has to be removed. Sequential suture removal can be done for selective tight suturing remove, and then overall the refractive correction has to be given after 1 month of all sutures are removed. So main thing here is to how to prevent. So prevention can only be the best thing for the getting the cure. So this counseling should be done to not to get the similar trauma in other eye or the same eye again. And the protection of the eye has to be done with special glasses or any special measures should be taken in the employment side. And counseling of the visual outcome post surgery also is mandatory, because it is a globe and it has got all other every structures of the eye is involved, so the visual outcome should be clearly explained to the patient and also attender. In practical purpose, we have seen that 30% of the people lose about 30% of the vision even if the surgery is done perfectly all right, even if a lens is put, even if there is no retinal hemorrhages or no retinal breaks, the 30% of the visual outcome is lost, and that has to be really emphasized before the surgery itself. Thank you for your kind attention.
Thank you, sir, for your talk. I think you have covered most of the points of 5-point management. Next, I'll invite Dr. Madhu, sir, for his topic on traumatic cataract and lens subluxation. Rings and hooks come to the rescue.
Good morning, everyone. My topic is of presentation. Thank you, Pius and AIOS, for giving me the opportunity. Uh, my topic of presentation: how hooks and rings helps in management of traumatic subluxated cataract. So I have no financial interest to disclose. As you know, cataract surgery in traumatized eye is the most difficult situation commonly encountered, and surgeon must prepare for any expected or unexpected situation to give best outcome. So, uh, this type of obvious signs of subluxation like phacodonosis, vitreous in anterior chamber, lens subluxation, or iridodonosis, it is less likely to miss. And if you observe vitreous in anterior chamber just in pre-op period, then you can anticipate a slightly larger area of dialysis than what it is seen in pre-op. So first you have to tamponade the area of this vitreous with dispersive viscoelastic. We have to look for the subtle sign of subluxation when we are dealing with the history of trauma, or this one like visibility of lens equator in eccentric gauge, iridolenticulaar gap, focal iridodonosis, or displacement of Y sutures. Sometimes if this type of subtle signs are missed pre-operatively, then we have to look for some early sign which will indicate the uh, signs of subluxation. So in this case, you can see that while functioning with cystitome, you can see the dimple sign. Uh, Means it will indicate that there is a 360-degree joindral weakness. So you have to manage accordingly. Or in this case, you can see that I am finding it difficulty in raising the flap. When you are, means some contraction is not there from jonules to initiate the rhexis. Means you have to be careful and you have to plan your surgery accordingly. This is also one of the sign when you start doing rhexis and you see there is wrinkling of peripheral anterior lens capsule, then you can anticipate some degree of joindral weakness. So in this case, you can see in the periphery that anterior lens capsule is wrinkling. So coming to management, like when we are planning for rhexis, we have to plan rhexis slightly start our rhexis from area away from the area of dialysis, and we have to plan rhexis slightly larger in the area away from dialysis and smaller in the area of subluxation. And the placement of hooks, you have to make your paracentesis slightly posterior to limbus so that when you hook the capsule, it will support your bag parallelly. And every 3 clock hour of subluxation should be supported by hooks. And care should be taken that it should not stretch your capsule too much so that you avoid anterior capsule tear. Sometimes after placement of iris hooks, if you observe some area of subluxation in small people or mid-dilated people, you may miss pre-operatively. But when you see that after putting hooks, area of subluxation was noticed. So after rhexis, you can transfer the same hooks over the anterior lens capsule to support the bag. Sometimes if you are very much vigilant, then you can observe some signs of subluxation or general damage intraoperatively. Like in this case, you can see there is slight fluctuation and deepening of anterior chamber. You can see that deepening of or some fluctuation means it indicates that you have damaged the jonules. So early intervention will prevent uh, you from further damage. So placement of CTR, it depends on degree of dialysis or degree of joindral weakness. If it is a gross subluxation, then you can plan for early placement of CTR. But the CTR can be postponed as much as possible because it will interfere with cortex aspiration. So in this case, first case, I implanted before nucleus management. In second case, I implanted after nucleus management, after cortex was. So your cortex was will become easier. In grossly subluxated lens, uh, it is preferable to place the IOL in the sulcus, 3-piece acrylic IOL in the sulcus, and make it do it make that reverse optic capture, do reverse optic capture, so that long term stability will be more. You can that optic will stabilize your bag for long term, and late post op dislocation will be not there. So in this case, I am planning to place the 3-piece IOL in the sulcus with reverse optic capture, so that stability will be more for post-op period. It is important, post-op follow-up, like early post-op period, because of big jaundice, chances of early phimosis is more in these type of cases, glaucoma and uveitis you have to look for, and late post-op you have to follow them for long term also to look for any IOL dislocation or dysenterism. Thank you.
Next, I'll invite Dr. Shamila for her talk on management of traumatic glaucoma.
Good morning, everyone, and at the outset, I would like to thank Piyush and AOC for the opportunity. So for the next few minutes, I'm going to be talking about the management of traumatic glaucoma. We all know that traumatic glaucoma is one of the major causes of blindness. It is important to understand and identify the causes for high intraocular pressure, because if you understand the causes, it is easier to choose the appropriate treatment options. So traumatic glaucoma is due to multiple causes. It could be because of blunt or lacerating trauma. It could be because of a chemical exposure or exposure to radiation. Amongst these, chemical exposure is the predominant cause for glaucoma, which is seen in around 75% risk of glaucoma, followed by lacerating or blunt trauma. The presentation of glaucoma could be early or it could be very late, and it could be reversible or irreversible. So there are certain predictive factors which influence the development of glaucoma. One is patients with higher age, those who have a lens injury, and those who have a very high intraocular pressure at presentation with presence of hyphema or any excessive pigmentation in the trabecular meshwork. And most importantly, when you notice a patient who have angle recession of more than 180 degrees, then they have likelihood of going in for glaucoma. So how do we record intraocular pressure in these patients? We all know they are all with acute trauma, so you might not be able to use your applanation tonometer in all of these patients. So it is important to identify an area where the cornea is relatively clear, and you can use instruments like an IK tonometer or a tonopin or a Dighton tonometer. And sometimes it might not be possible to even use these instruments, so we'll have to just go with our digital or tactile sensation and compare it with the other eye. It is important to compare it with the other eye. You use the other eye as a reference to see if the pressure is low or high. Not always we see patients with trauma having high intraocular pressure. Often we do see patients who have low intraocular pressure. Why do we have low intraocular pressure? Because of inflammation, ciliary shutdown, or it could be because of a cyclodialysis cleft. So gradually these patients, when you treat the inflammation with steroids, and then when you close the cyclodialysis cleft surgically, then you have an increase in intraocular pressure. So you have dual mechanisms acting, and you'll have to treat them accordingly. So the mechanism of glaucoma could vary according to the type of injury. It could be because of a closed globe injury, open globe injury, or chemical injury. So amongst these, the closed globe injury is the most severe one, and it is often difficult to treat, and it requires definitely a surgical intervention. So what is the mechanism of glaucoma in these closed globe injury? It is mostly because of angle recession or a mechanical damage to the trabecular meshwork. Whereas in open globe injury, there are less chances of trabecular damage. However, it is because of a lens trauma, lens subluxation, or induced uveitis. So here it is because of lens-related mechanism, so we'll have to tackle the lens. And in chemical injury, the alkali burns are more severe than the acid burns. And how does this lead to glaucoma? It causes shrinkage of the collagen, causing obliteration of the trabecular spaces, and thereby increasing the resistance to aqueous outflow, or it could be because of inflammation and synecdoche. So, whatever is the mechanism of glaucoma, your treatment could be either simple if you identify the underlying cause, or it could be really very challenging depending upon the mechanism of damage. By and large, the treatment of traumatic glaucoma is usually by conservative medical management, which we start off with anti-glaucoma medications, steroids, and cycloplegics. Most of this, if it is because of an inflammation, it will subside. If it is because of a lens which is causing a pupillary block with a subluxation, you definitely have to go ahead and do a laser peripheral iridotomy. Or if there is a dislocation either into the anterior chamber or into the vitreous cavity, one has to go for a lens extraction. And if there is a hyphema which is persistent for more than a week with a very high intraocular pressure, you have to go for a AC wash. If none of this is helpful and still the pressures are very high and it is refractory, it was often important to think about a surgical option like trabeculectomy, GDD, or a cyclophotocoagulation. So the medical management has proven to be helpful in around 60 to 80% of patients if it is because of an inflammation. So you generally give more steroids, cycloplegics, and start off with anti-glaucoma medications. However, there are situations where we might have to go for a trabeculectomy. And when you're doing a trabeculectomy, the only tip I would like to give here is you have to use high dose of antimetabolites, unless in otherwise it's contraindicated, especially when there is a scarred conjunctiva or chemical injury induced damage. But I strongly prefer to use a glaucoma drainage device because these eyes have been exposed to trauma. There is a lot of variations which are happening in the conjunctival cytology. There's more chances of fibrosis with trabeculectomy. So I prefer to go for a glaucoma drainage device. And my choice would be to go for an RD with a supramid stenting. And also you can even use an AGV implant. And we have to remember that the conjunctival closure might not be very adequate depending upon the trauma. So one might have to also think about using an autograft from the other eye or use an amniotic membrane graft if there is a deficiency in conjunctival closure. The other newer kid on the block is a micropulse. This micropulse is very good, especially in patients with good vision. So you have an option of reducing the intraocular pressure without causing much of collateral damage, or chances of phthisis or hypotonia are very less with micropulse laser. So I prefer to use a micropulse when there is a very high intraocular pressure and surgery is not needed immediately. So how to treat different clinical scenarios? So we know that angle recession glaucoma is the most common one. And in patients who have hyphema, angle recession is seen in around 71 to 100% of patients. So 7 to 10% of them develop glaucoma over a period of years after the injury. So what is important here is you might not just see that like you treat the patient immediately and then the inflammation comes down, intraocular pressure comes down, and then you forget about the patient. It is important to follow up all these patients annually with the gonioscopy, especially in those patients who have an angle recession of more than 180 degrees at the first visit. Lens subluxation or dislocation, I think it's the most easiest one to treat because you know the culprit is because of the lens, so you tackle it accordingly. So like what you see in this picture, you see that lens subluxation, and it is partly in the anterior chamber and partly in the posterior chamber. So here what you do is it is causing pupillary block. You have to treat it with LPI if there's very high pressure, and then go ahead and remove the cataract and then treat them at the same sitting or later with a secondary intraocular lens. And if there is a dislocated lens in the vitreous cavity, one has to think of doing a pars plana vitrectomy with an SFI. Lens particle glaucoma is also something which is very commonly seen because often there is a damage to the anterior lens capsule. So once there is a damage to the anterior lens capsule, you have a lot of these lens particles coming out, and there is a macrophage response to that, causing very high intraocular pressure. In any case, when there is a prolonged persistent inflammation and it is not getting controlled with steroids or cycloplegics, that should ring a bell saying that probably there's something inside the eye which is still present, and you have to do an imaging to rule out any persistent intraocular foreign body. Hyphema is the most common cause for high intraocular pressure. However, most of the hyphemas will respond with steroids and cycloplegics. Only 5% of them might need a surgical intervention. So when do you take the patients for surgical intervention? When there is an intraocular pressure of more than 50, which is present for more than 5 days, or when there is an intraocular pressure of 45 and more for 1 week, or if there is an intraocular pressure of 35 and above for more than 2 weeks. Hemolytic or ghost glaucoma is all because of the hemoglobin filled macrophages or breakdown products of red blood cells that obstructs the trabecular meshwork. Here you do a simple medical treatment, or you might have to think of AC wash, vitrectomy, or trabeculectomy. So orbital hemorrhages are also quite common depending upon the nature of trauma. So you see a red eye like this with a proptosed eye. So there is an intraorbital hemorrhage with extremely high intraocular pressure causing a compression of the optic nerve, causing relative afferent pupillary defect, drop in the visual acuity. You can see a pale retina and extremely severe pain. In such patients, it's important to get an orbit opinion and go for a lateral canthotomy to relieve the intraocular pressure with or without inferior canthrolysis. So the take home message here would be, it's important to identify the problem or the cause and prompt treatment is initiated. Careful monitoring of intraocular pressure, angle status, pupils, disc and lens status is very important. Treat the underlying cause for high intraocular pressure. Most traumatic glaucomas often require surgical management. However, individualize the treatment based on the mechanism of glaucoma. Thank you for patient hearing.
So now moving on to the posterior segment, manifestations of closed globe injury. So patient with blunt trauma may look innocuous in the first look. So what we need is a careful and detailed history taking as well as fundus examination necessary to rule out the collateral damage. So like this is a patient which looks very innocuous with a subconj hemorrhage, but the first thing we have to do is rule out any occult globe injury. So what we find when we dilate the patient, there's an intraocular foreign body that has gone inside. So now the management changes and now we have to go for a vitrectomy with intraocular foreign body removal. So what happens to an eye when it receives a blunt trauma? The maximum damage occurs at the point where the blow is received. Then a compression wave force is transmitted through the intraocular fluid in that direction, causing contracoup damage. After striking the outer coats, it is reflected towards the posterior pole, and then finally it will rebound anteriorly. So all these forces will cause their own damage. So coming on to the epidemiology, the rate of retinal involvement among eyes with closed globe injury is 34%, while the rate of vitreous involvement is 22%. So posterior segment manifestations will be vitreous hemorrhage, lens dislocation, vitreous base avulsion, optic nerve head avulsion, traumatic optic neuropathy, Berlin's edema, macular hole, choroidal rupture, RPE tear, subretinal hemorrhage, chororetinitis scleropetra, retinal tears and retinal detachment. So first is the vitreous hemorrhage, which is caused due to damage or to blood vessels of iris, ciliary body, retina, choroid. It can range from little to total vitreous hemorrhage. It may be associated with retinal breaks or it can be associated with Terson syndrome. So management is you have to screen periphery for the presence of retinal breaks and you should follow the patient until you see 360 degree of aura. We can perform a serial B-scan ultrasound if there is no fundus view to rule out retinal detachment, optic nerve head avulsion and vitreous incarceration. The patients with vitreous hemorrhage can be observed for spontaneous resolution for 4 to 8 weeks, after which we'll have to go for surgery. So what are the indications for early vitrectomy? If the patient vitreous hemorrhage is associated with retinal detachment or a large retinal tear, non-resolving vitreous hemorrhage, ghost cell glaucoma, single-eyed patient, bilateral vitreous hemorrhage, or if there is subretinal hemorrhage. Second is the lens dislocation, which can happen with its capsule. The management is simple. You have to go for a pars-plana vitrectomy and lensectomy. SFIL can be done in the same sitting or different sitting. Vitreous-based avulsion. What you see is a bucket handle sign, that is a part of vitreous drape is over the peripheral retina, what we can see in the inferior nasal part of the eye. The symptoms are minimal. It does not cause RD per se, but the clinician has to look for retinal dialysis, GRT and angle recession glaucoma. It does not require any intervention, but you have to closely follow the patient. Then optic nerve head avulsion, the rupture of optic nerve head at disc margin without damage to the optic sheet. The postulatal mechanisms are direct trauma to the globe, sudden marked IOP rise, which can force the nerve out of the scleral canal, shearing force from the acute globe rotation. It can be either complete or partial. Incomplete, you will see a blind eye with a fixed and dilated pupil. This is the case of optic nerve head avulsion. On the left side is the early sign, and on the right side is the late presentation. B-scan, ultrasound, CT and MRI only partially successful. It can also lead to vascular occlusion. Most common are the CRO. Then coming on to the Berlin's edema or commotio retinae, it is a self-limited transient whitening at the level of deep sensory retina. 9.4% accounts for 9.4% of post-traumatic fundus changes. It is actually a misnomer because there is no actual edema. It is caused by disruption of photoreceptor outer segments. It may take hours to develop and there is no proven treatment. It can be of two types, the milder version, that is the concussion, and the severe version, that is the contusion. The initial vision will be obviously worse in the severe version, which will be associated with more intense retinal whitening and retinal hemorrhages. Recovery is usually complete in retinal concussion, while retinal contusion will leave some pigmented scars and visual recovery is not complete. If you do an FFA, there will be no findings in concussion, while in contusion, there will be intense staining or a leakage. This is the late photo of contusion. Always remember to record the baseline visual acuity for both eyes, to document presence or absence of RAPD, to examine other eyes for the presence of signs of trauma or pre-existing disease. Normal anterior segment vision should not deter the clinician from performing dilated retinal examination. Thank you. I thank Chitranjan sir for providing the images. Next, I call Dr. Ubli to continue with the other complications.
Good morning, everyone. So today we will be discussing about the posterior segment manifestations of blunt trauma. This is part 2 of the presentation. So what we will be discussing is macular hole, choroidal rupture, subretinal hemorrhage, chorioretinitis glomerulosa, retinal tears, and retinal detachment. So coming to traumatic macular hole is posterior, opposed to the traumatic central discontinuity of the retinal layers. So traumatic macular hole accounts for 10% of all the macular holes. PVD is typically absent, more eccentric and less circular than idiopathic macular hole. Horizontal diameter is significantly longer than vertical. There is no consensus of management. Spontaneous closure occurs in young patients and smaller holes, which is less than 1/3 of the disc diameter and without a fluid cuff. Late surgery lessens the chance of good anatomical recovery and functional recovery. This is a case where we had a pre-op, and this is the post-op showing the closure of the macular hole. So now coming to the second manifestation, which is choroidal rupture. Choroidal rupture is defined as post-traumatic discontinuity of the choroid, which may or may not be associated with discontinuity of the overlying retina. Choroidal rupture of the inner choroid, overlying brush membrane, and RPE, which are relatively inelastic, whereas the fortified collagenous sclera and the flexible retina are less likely to rupture. Incidence is 5 to 10% in the blunt traumas. Coming to direct, two types of the choroidal rupture. There is a direct choroidal rupture and there is an indirect choroidal rupture. Direct choroidal rupture is uncommon, parallel to the aura at the site of the impact and usually anterior to the equator, whereas indirect choroidal rupture is more common, compressive injury to the posterior pole, which is associated with crescent-shaped tears occurring concentric to the disc. Majority occur temporal to the disc, may involve fovea. Patient with angioid streaks are more susceptible, associated with intraretinal and subretinal hemorrhages. This is an OCT of a choroidal rupture passing through the fovea with an overlying retina which is discontinuous. And this is an OCT of a choroidal rupture passing through the fovea with an overlying retina which is continuous. This is a picture of a choroidal rupture which shows a fundus picture montage showing a choroidal rupture with retinal tear, subretinal hemorrhage, and there is a macular degeneration also present. Coming to the next manifestation, which is a subretinal hemorrhage, collection of blood between the RP and the neurosensory retina. Subretinal hemorrhage is classified according to the size as small, medium, and massive. Small is less than 4 disc diameter, medium is more than 4 disc diameter, but does not extend beyond the temporal vascular arcade. And the last one is massive, which overspreads the temporal vascular arcade. This is an OCT showing a massive subretinal hemorrhage. So, the main damage of the photoreceptors occurs due to iron-related toxicity, impairment of the diffusion of oxygen and nutrients, mechanical damage due to the clot contraction. Treatment options: there is pneumatic displacement, intravitreal tissue plasminogen and activator injection with pneumatic displacement, subretinal injection of the tissue plasminogen with pneumatic displacement. This is a case which we had operated, showing a pre-pneumatic displacement, and this is showing a post-pneumatic displacement with almost all the subretinal hemorrhage which is gone. Now coming to chorioretinitis scleropateria, rupture of the choroid overlying brush membrane RPE, neurosensory retina, secondary to high velocity projectile hitting adjacent to the globe but not penetrating it. So this is a case. It looks usually very dangerous, but the major thing is that the visual acuity and the visual prognosis depends on whether the macula is involved or not. So this is one of the cases which we had seen in Arvind. This is a 18-year-old male who had sustained an injury while playing a gilli danda. The patient's presenting visual acuity was 20 by 40. Two adjacent chorioretinal tears you can see anterior to the equator with a thin strip of retina between them and bare sclera underneath. The teared up retinochoroidal complex is seen lying next to the tear. The management of chorioretinitis scleropateria management is controversial. The incidence of acute retinal detachment is low. The chorioretinal scarring is usually present. Usually in young patient, formed vitreous and intact posterior hilar tamponades the breaks. Late RD has been reported in 1/4 of the patients. Retinal breaks at the site distance to the original choroidal rupture is usually noted. Visual prognosis, as I told, is depends upon the location of scleropateria and the status of macula and optic nerve. Coming to the final thing, traumatic retinal tears and retinal detachment, neurosensory retinal detachment post-trauma due to the traumatic retinal tears. Pathophysiology, sudden and rapid globe distortion, anteroposterior shortening and equatorial elongation. Globe is unable to adequately stretch inelastic eye walls. Volume of the eye remains constant, vitreous resistant to the compression, generates tractional forces within the globe. Sites of the tears, there is vitreous base avulsion, abnormal sites of vitreal adhesion which causes holes and horseshoe tears, coop injury where there is a full thickness necrosis at the site of the scleral impact, sudden PVD induction which causes horseshoe tears. Most common location of the retinal tears is the infratemporal quadrant. Retinal tear detachment may develop even years after the original trauma, so frequent follow-up is necessary. This is a picture of showing a giant retinal tear with retinal detachment post closed globe injury. This is a case which is a post closed globe injury, which is showing a superior giant retinal tear, a vitreous hemorrhage, and also you can see superior commotio retina also noted. Management, laser coagulation and cryopexy, retinal detachment associated with retinal dialysis, scleral buckling is the mode of treatment. Retinal detachment associated with giant retinal tear, pars plana vitrectomy is the mode of management. And as Dr. Piyush told, it's always important to record the baseline visual acuity, to document the presence of RAPD, to examine the presence of other eye for also trauma, and normal anterior segment vision should not deter the clinician from performing dilated fundus examination. Thank you. My regards to Dr. Piyush, Dr. Nari sir, and my fellow Anuja. Thank you.
Next, I'll invite the senior most member. Next, I'll invite Dr. Padmavati for managing traumatic optic neuropathy.
Very good morning. At the outset, I would like to thank the Chief Instructor for including me to deliver this talk. The topic assigned to me is managing traumatic optic neuropathy. As everyone knows, it is one of the potential visual debilitating conditions following trauma. If you see, you have it in 0.5 to 5% of closed head injuries, and the incidence of traumatic optic nerve damages in 2.5% of midfacial fractures and in 10% of craniofacial fractures. The types of injury, it could be a direct or an indirect. The direct is where you have a penetrating injury to the optic nerve, that is as shown in the diagram, and the indirect is following just before the blood vessel, where you have a visibility, what you can find a structural damage which is seen in the fundus, whereas an indirect is the intracanalicula portion which is affected, where the fundus is absolutely normal and you have a vision loss. The pathogenesis of your vision loss here is by mechanical factors. The next is your secondary injuries because of the vasospasm as well as of the edema within the optic nerve. So how do you manage these cases? The management, you have various options available. One is conservative, one is steroids, one is surgery, or a combination of steroids and surgery. So the biggest dilemma is what is the consensus for management these cases. The challenges here is there is no evidence-based guideline for evaluation as well as therapy of traumatic optic neuropathy. And moreover, you don't have a large natural history and a large randomized controlled study which gives a level 1 evidence to substantiate this is the consensus for managing a case of traumatic optic neuropathy. This was an article which was published in the Current Opinion in 2009. So as you see, as traumatic optic neuropathy leads to profound visual disability because of the lack of evidence supporting it, whatever we are managing these cases are only on group level 2 evidence and level 3 with a smaller groups reporting it. So what was the rationale for using a corticosteroids? This reduces the traumatic edema and limits the severity of contusion necrosis of the nerve. This also helps to reduce the degree of vasospasm which accompany the trauma. The various studies which included here, which provided the group 2 evidence is, these patients received IV methylprednisolone 1 gram daily followed by oral steroids for around 11 days were compared with the placebo patients, and they found that the steroid therapy did not result in any statistically significant improvement in vision compared with the placebo. The next, the NASIS is the National Spinal Cord Injury Study, where they found that methylprednisolone, if it is given in bolus, followed by an infusion by 5.4 milligram per kg per hour, they found that there was improvement in the neurological scores which is given in 8 hours. That is the CRASH study which was conducted in 2004. That is the corticosteroid randomization after severe head injury. That showed that there is increased mortality when you give a high dose with traumatic brain injury. So the role of steroids was controversial here. This was only the prospective study which supported the observed treatment options. One was given steroids, one was given a surgery, and the other was a placebo group. But the final conclusion was neither steroids nor surgery had any benefit in this. So if you see in this study, which was the largest study, I think Yan et al., where they had seen in 1,275 patients, they received intravenous methylprednisolone with optic nerve decompression. They found that best corrected visual acuity improved significantly, but the complications, if you see, there was more of 15 CSF leaks. So the next, what were the next strategy to manage these cases? So they next went on to the neuroprotective therapies. One is the erythropoietin, which is a cytokine hormone which promotes hematopoiesis. This can reduce the apoptosis in neurons. This exerts the protective effects which has been proven in animal models. So erythropoietin studies was a one study, major study which was done here in 2018. 69 patients received intravenous erythropoietin, with some of them were also treated with IV steroids. So what they found was, there was no statistically significance between the two groups. The erythropoietin was also a treatment option which was done in Arvind Madurai. They found that both were effective in the management of traumatic optic neuropathy. So the future treatment options are on these to regenerate the axons, protect the retinal ganglion cells. To conclude, there is no level 1 evidence to substantiate a standardized protocol for the management of traumatic. There is a need for large prospective randomized controlled trial. And the research is on new drugs, mechanisms, and techniques which provides new ideas for treating traumatic optic neuropathy. And till you have, it is only on the case-to-case based scenario where you have to take up the decision to give a steroid or a optic nerve decompression. Thank you.
Next, I invite the senior most member of this group, Dr. Naresh Babu, who has been serving as mentor and teacher for the last 25 years.
Good morning, all. Dr. Piyush Kohli, thank you very much for the invitation. And he wanted to reveal my age, I don't know why. It's okay, all in the game. Right. So today we'll be discussing about the retrieval, the localization and the retrieval of the foreign body. I think we have got very less time. So mostly we'll be discussing about the localization of the foreign body because it's a big medical legal issues. In fact, many of the cases which we have faced are because of the intraocular foreign body either missed or mismanaged. So open globe injury most of the time it is associated with a very bad visual prognosis, and now with a lot of this during this COVID time, we have come across a lot of open globe injury, especially among the teenagers and the young adults, and we have come across a lot of this industry-based injuries also. Most of the people who work in this lathe and other thing will not be using any protective glasses with open globe injury and a lot of intraocular foreign bodies. So we come across few cases. That means they might have had more number of injuries. So whenever we see a patient, there is always a clue. This case, one of the very important case, this case had a lid tear and there was some subconjunctival hemorrhage. But believe me, the people have not done any X-ray. So this is a clue. Whenever there is a hemorrhage and there is a small lid tear, they just send the patient off. But when the patient came to us on dilatation, you can find the intraocular foreign body with some hemorrhage inside. So if there is a very subtle tear, just dilate and look what is there in the fundus, because the best way of localizing the foreign body is immediately dilating the patient and directly visualizing the intraocular foreign body. So in any case of intraocular foreign body or any open globe injury, counseling is very important, and we have to do it in groups. Actually, you call all the relatives if possible, so that it will not be, I mean, a problem to explain each and everyone individually. And sometimes, or most of the time, I have been very brutal in telling the prognosis, because they should not have very high, expectation after the retrieval of the foreign body or the open globe injury. And need for multiple surgeries have to be emphasized. And let us be very frank about the prognosis. And finally, we have to tell that, because most of these people are young, we have to tell about the thesis also. So in case of intraocular foreign bodies, almost 18% of the posterior segment trauma will be having some form of foreign body, and 40% of the open globe injury, when we see, they'll be having some form of intraocular foreign body, which is there inside the eye, and most of them are male, and that is because of chromosome, I think, because XY is irregular and the patients are, I mean, men are also irregular. And what we come across is because of the hammering of the chisel and without any protection, and this is what is very commonly seen. 60-80% are foreign body, and in hammering and chisel usually it will be a single foreign body. If we come across multiple foreign body, even if the patient denies, we have to suspect some blast injury. The usual history is, which is told to us, is the burst of tire, which is sometimes unbelievable actually. And commonly the foreign bodies are metallic and magnetic, so retrieving is very easy. And there is always a risk of infection, retinal detachment, and if it is left inside the eye for a longer time, in case of iron, we'll be having cirrhosis, and charcosis can present like an acute endophthalmitis picture. And usually if it is gold, it is usually, they say, non-reactive, but pure gold is non-reactive, maybe 24 karat. We don't come across a pure gold. Even the ornamental gold is 916, and if the patient is having some form of reaction because of the copper inside the foreign body, you can blame the goldsmith that it is adulterated more with the copper. So that is a clue that we have a thing. So the other inerts are glass or gold or porcelain. Usually glass foreign body, if you don't have a proper forceps, just leave it inside because it is inert, it's not going to cause any damage. But retrieving a irregular glass foreign body can lead to a lot of collateral damage. And the common sites are corneal in more than 65% of the cases, scleral it's 25, and only in case of 8 to 10% will have more than one foreign body. Unfortunately, we don't have this blast injuries in our part of the country, so we don't come across multiple foreign body. And it is present in 70% of the cases in posterior segment. And again, it depends on the velocity, nature, and the size of the foreign body. So this is a case who came to us. We could see some 2 or 3 pins in the conjunctiva. Oh, sorry. Okay, so this was the X-ray. The left one was X-ray which was taken elsewhere. The other one was done by us. So you can see the difference. There were some few 10 pins in the other eye, and the other 10 pins, more than 60 were found in this eye. So this is the 3D construction of the what you call CT, where you can find multiple what you call pin-like structure inside the eye. When we inquired, actually this is a self-inflicted injury. The history was this guy was not getting married, so he was so depressed, so he was breaking the hypodermic insulin needle and inserting inside the eye. I was telling, like, if you would have got married, you would have had pins in both the eyes. So history is also important. Then he was given counseling and treatment. The other eye, we removed the foreign bodies, but we could not revive the vision. So the best method of localizing the foreign body is direct visualization. Dilate immediately, look for the foreign body, and we know where exactly and what the size is, so that we can plan for the surgery. And plain X-ray is very, very important. Even if you do other investigation, do a plain X-ray. PAVU is the one which is mandated because it will eliminate the bone shadows. The reason why I'm saying plain X-ray is important is for medical legal purpose. Because I have come across cases where they have not done the X-ray, and when the patient went to the court, the concerned doctors have lost and they have paid the penalty also. Just whatever may be the history, even if it's a blunt injury, do a plain X-ray just to rule out a foreign body or just for the medical legal purpose. Usually, if it is a glass, it's not visualized. If there is more silica content, then it can be seen, but it is not very precise in localization. So in case if you don't have other methods like ultrasound or what you call CT or MRI, we can use a radio opaque marker. There are so many ways. One is the Fleringer's ring. With this, you just put it, take a lateral view, the ring should be in a single line. From that, you create an artificial eyeball, and with this, we can localize whether the foreign body is inside the eye or not, so that it is easy for us. So this was a case who had this baldness injury. So before going in for CT, we did in ultrasound we couldn't localize this foreign body. So then we did a Fleringer's ring in this case. But if you see on lateral view, actually the foreign body was quite posterior. Then when the CT was done, it was in the frontal lobe of the brain. So sometimes we'll have surprises. This foreign body obviously was not removed. Ultrasound is a very important thing. Many people say you should not do it, but if the injury is not very extensive, we can do it. It's very highly sensitive, and the most important thing is the collateral damage, like the vitreous hemorrhage or retinal detachment or the choroidal detachment, lens rupture. All those associated things can be easily identified with an ultrasound. Do a gentle ultrasound. Doing ultrasound is not a contraindication in case of injury, unless otherwise it is a totally flat eye. But there are certain disadvantages because it can expel the contents, and the specificity is poor. But UBM is best in case if the foreign body is anterior, but we cannot do it in acute injury cases. So the other thing is a CT scan. Usually we do in most of the cases a CT scan to localize the foreign body. It is very sensitive, and it can detect a foreign body of 0.06 cubic millimeter. And if it is more than 0.06 millimeter, in 100% of the cases, the foreign body can be localized with a CT scan. And spiral CT is superior to the conventional CT. Even the smallest can be identified. So the last one will be MRI. But before doing MRI, always rule out the foreign body is not metallic, because the foreign body can move up to 7 to 8 millimeters in the suprachoroidal space, or 10 millimeters inside the vitreous cavity when the MRI is done. So that can lead to a lot of collateral damage because of movement. So once if you rule out, in case if it's a wood or other plastic, if you want to localize and find out, go for MRI. But the disadvantages, we all know that there is no visualization. And if the patient comes with the sequelae of foreign bodies, then we have to suspect certain things. If you find this the brown ring with a lot of pigmentation, there could be a possibility of siderosis. Usually these people come with a long ago history of injury. So in case of siderosis, clinically it is easy to identify because the affected eye will be dilated and it will be hyperpigmented. Most of the time we'll be thinking that it has been medicated, that's why the pupil is dilated. Usually the pupil is dilated and hyperpigmented. And we have to do ERG in case of what do you call the cirrhosis eye. Initially, there will be response. Over a period of time, there will be what you call the reduction in the B wave. And finally, there can be a flat ERG. The thing is, if the ERG is flat, still we have to operate, provided we have to do EOG also. If the ERG is flat and the EOG is also flat, and that is the condition where the prognosis is very bad or zero. But if the ERG is flat, but still the EOG is good, we can go ahead and remove the foreign body, usually under the steroid cover, and usually they do very well. So a flat ERG in case of cirrhosis eye is not a contraindication. This is one of our series where we have published more than around 17 cases of the ocular cirrhosis eye, where we could find the the reappearance of the waves in the ERG.
I think we'll take up questions.
Yes, so I
From the
think the
audience.
retrieval will just skip. So just we'll stop with the the localization, and we'll be happy to answer the question.
Yes, sir. Any questions from the audience? I think.
Yeah, I think what you're saying is true because it is like a persistent disintegrated red blood cells which are dispersed throughout the aqueous as well as it is blocking the TM. So in such cases, I think it is better to go for if there is a persistent high intraocular pressure, better to go for a surgical treatment. Yeah, earlier surgical treatment.
I think in view of time, we'll conclude this. Okay. Okay.
No need, because there will be surrounding scleroretinal scars which will form. So there is no need for any laser. And most of the time, even if RD happens, it will happen at a different place because of the PVD induction. Thank you.
Okay. Thank you. I think we'll conclude. Thank you.
Thank you.